Good afternoon, everyone. This is Sarah Lancashire from Cancer Care Ontario. Corwyn, can you hear me as well?
I can.
Okay, great. We're just going to start the session in just a moment. I would just like to make an announcement quickly before I hand it over to Dr. John Shigley. For those of you that are on the line, if you're having trouble accessing the video portion of the program in terms of actually seeing the video portion of the session, for whatever reason, there seems to be a password associated with this. So if you are having difficulties, the password, if you're being prompted for a password, seems to be pathology with a capital P. So I will just let you, if you would like to be able to re-log in from that perspective. If not, we'll actually start the call, the presentation now, and I'll just hand it over now to Dr. John Shigley.
Thank you, Sarah. I'm Dr. John Shigley, and I'm the clinical lead for the Pathology Checklist Project at Cancer Care Ontario, and also the chair of the National Pathology Standards Committee for the Canadian Partnership Against Cancer. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I'd like to welcome everybody to today's education session on the new CAP checklist for Exocrine Pancreas. That's going to be given by Dr. Dr Rowsell. Before I introduce our speaker and get going formally, I'd like to take care of a few housekeeping items. Firstly, today's presentation will be approximately 90 minutes in length and will include a 60-minute presentation to be followed by 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email links once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon completion and submission of evaluation forms available electronically. The information for accessing the evaluation forms was provided in the notice for the session previously distributed. Please note that CME certificates for each CAP checklist education session will only be issued for 1 month from the presentation date. The recorded sessions will be available electronically for an undetermined period of time, but the CME certificates are only available for 1 month. Please refer to the session notice for the exact deadline date. Please note that everybody's line has been automatically muted for today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of the teleconference, please call the WebEx support line at 1-866-229-3239. We encourage you to submit questions at any time during the presentation using the chat feature. For instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. During the question and answer portion of the presentation, in order to avoid question collisions, I will pose the submitted questions on your behalf as long as time permits and in the order in which they appear. In the chat window, would you please include the following information: your institution's name, the name of the individual posing the question, and finally your question. It is now my pleasure to introduce Dr. Dr Rowsell. Dr. Rowsell is currently the Director of Surgical Pathology at the Sunnybrook Health Science Center and is an Assistant Professor at the University of Toronto. His interest in hepatic, pancreatic, and biliary cancers began during his 3 years of general surgery training and continued after he decided to make a career change into pathology. For the past 5 years, he has worked in a subspecialized hepatic, pancreatic, and biliary practice, which has afforded him the opportunity to study and publish on topics such as pancreatic margin assessment, lymph node retrieval, as well as intraoperative consultation. Dr. Rowsell also has a strong interest in quality assurance in surgical pathology, which has led him to pursue involvement with committees and working groups for QMPLS in Ontario and also with Cancer Care Ontario. Without any further ado, I will turn the microphone now over to Corwyn. Corwyn?
Well, thank you very much, John, and thank you to all of our participants. And I look forward to our discussion at the end of the formal presentation. So first of all, my disclosure information. So I have no financial relationships to disclose, and I will not be discussing any off-label use or investigational use in my presentation. So just a couple of basic learning objectives today. First of all, the principal objective here is to review the components of the CAP checklist for reporting carcinoma of the exocrine pancreas. And I hope that we can try to understand better the clinical implications of features that are included in the CAP checklist. So first of all, just to clarify the College of American Pathologists protocol that we will be discussing today. So we're discussing the protocol for examination of specimens from patients with carcinoma of the exocrine pancreas. So this applies to all epithelial tumors of the exocrine pancreas. It does not include endocrine tumors or tumors of the ampullary vater. And this, of course, is based on the AJCC 7th edition. So I thought I would start off with some fast facts about pancreatic cancer. I think it behooves us to understand the beast that we're dealing with. So first of all, mean survival for pancreatic cancer without any treatment is 3 to 5 months. Mean survival for resected pancreatic cancer is 10 to 20 months. Obviously, there's some selection bias in here as the patients who are least advanced and have the least comorbidities are going to be those who are selected for resection. At presentation, only about 10 to 20% of all pancreatic cancer patients have a resectable tumor. Overall 5-year survival for all comers is 3 to 5%. Even with surgery, the recurrence rate is extremely high. 70 to 90% of patients will have recurrence of their tumor in 2 years. You can find all of this information as well as more in the WHO Blue Book from 2010. Another interesting fact is that a lot of pancreatic cancer resections are in fact R1 resections. There is residual tumor. And in a recent European paper, the R1 resection rate was up to 76% when a very fastidious grossing protocol was followed. Obviously, there are papers out there with much lower R1 resection rates, but the grossing protocol wasn't quite as fastidious. Basically, if you're not looking for margin positivity, you're not going to find it. A couple of other interesting facts about pancreatic cancer and basically the role it plays on the national stage. There was a very interesting poll from Ipsos Reid just last month that really showed that public awareness of pancreatic cancer was extremely low compared to other major forms of cancer. Of course, we would be talking about breast, prostate, colorectal, and lung. And the pollsters actually came to a very interesting conclusion as to the reason why. As we know, pancreatic cancer is a deadlier cancer than the other cancers mentioned. However, that may be one of the factors that leads to it being less known by most people. Because when people were asked, do you know a survivor of one of these cancers, obviously very few people knew pancreatic cancer survivors. So even though there have been a lot of well-known stars who have had pancreatic cancer and died of it, there are very few survivors left to advocate for pancreatic cancer funding. And in fact, the Charity Intelligence Canada says that pancreatic cancer is the most seriously underfunded cancer, as less than 1% of research and charitable funding for cancer goes to research for pancreatic cancer. So these are pretty abysmal facts and statistics, and if you dwell on this too much, I think you might feel like this guy. This is Sisyphus, who's a character from Greek mythology, and he tried to cheat death and was successful, but his punishment was that he had to roll a stone up a mountain every day, after which it would roll down again, and he would have to roll it back up in perpetuity. And I think sometimes it's tempting when we're looking at a pancreatic cancer specimen to feel that same sense of futility that that basically whatever we say, this patient has a poor prognosis and may not live out the year. Add to that the fact that we don't have the fancy biomarkers that some of our colleagues who are interested in other cancers have, or the kind of a star power of breast or prostate cancer. and basically you can start to feel a lot like Sisyphus. However, I want to emphasize that I think there's a very big role for the pathologist in pancreatic cancer. Certainly, the information that we put in our pathology report is valuable for prognostication. It does guide treatment decisions, and certainly it's very important in terms of data collection for cancer registries and epidemiologic studies so that we can better understand this disease. And another role that I'd really like to highlight here is that of audit and feedback. And I think that's a really big role for the pathologist these days. And when we look at these specimens, I think it's really our role to feed back our findings to certainly the surgeons and the radiologists about where positive margins were found that weren't suspected based on the preoperative imaging or the intraoperative findings, and also now even to our medical oncologists and radiation oncologists, given that there's actually a role for neoadjuvant treatment in pancreatic cancer. And certainly a great forum for audit and feedback are MCCs, or multidisciplinary case conferences. So now on to the checklist. So the first part of the checklist is the specimen. And of course, the Whipple specimen is one of the more complicated specimens that we get in cancer pathology. And certainly by definition, it's a multivisceral resection. So parts that we may receive are the head, body, and tail of the pancreas, the duodenum, the stomach, the common bile duct, gallbladder, spleen. Sometimes now with more aggressive surgery for pancreatic cancer, we get the adjacent large vessels, and sometimes other. We have certainly seen locally advanced pancreatic cancers that have gone into the colon or the posterior wall of the stomach resected. So there are various procedures that we may see. Certainly, we're all familiar with the Pancreaticoduodenectomy, or the Whipple resection, and this can be done as a partial pancreatectomy, which basically just entails the pancreatic head, or a total pancreatectomy. This one we see much less often, obviously because of the serious morbidity that's caused by a total pancreatectomy. Sometimes, of course, for more distal tumors, we will see partial pancreatectomies of the pancreatic body or the pancreatic tail. So here's an example of a pancreaticoduodenectomy specimen. I'll show you a posterior view later. But just to orient you, here's a piece of gastric antrum, the papilla, the duodenum, the common bile duct. And of course there are variations on this procedure. One common variant is the pylorus sparing variant, where you don't have this little cuff of gastric antrum. And of course then there's the distal pancreatectomy and splenectomy. This is a less complicated technical procedure, and it's also much less complicated for us as pathologists to gross and assess. Really the key component here, aside from the tumor itself, is the proximal pancreatic margin. So next we come to the tumor site. So pancreatic tumors can be located in the pancreatic head, the uncinate process, the pancreatic body, or the pancreatic tail. Now, this is just a diagram right out of the CAP protocol, and this just outlines the divisions of the pancreas into head, body, and tail. So you can see that the dividing line between head and body is just this line to the left of the superior mesenteric vein, and the dividing line between body and tail is the left side of the aorta. Then we come to tumor size, and the key component here, of course, is to put the greatest dimension. Now, of course, those of us who look at pancreatic cancer specimens know that the gross estimate of tumor can be way off for one of two reasons. One, that there's a lot of surrounding chronic pancreatitis, and we are in fact overestimating the tumor size, or more often than not, we are in fact underestimating the tumor size on gross as the tumor is kind of percolating through the pancreas in an irregular fashion. Now, greatest dimension really becomes of key importance only if the tumor is confined to the pancreas. And in general, that's the exception rather than the rule, certainly in our practice. So if the tumor is 2 centimeters or less, that is significant, provided that it's not invading any adjacent structures. Then we come to histologic type. And there's a number of histologic types that are specifically listed in the protocol. There are more if we search the literature. The key point is that most of these are quite rare, and I'm just going to highlight a few of them that we might see more often or are of particular significance. Of course, the most common is your run-of-the-mill ductal adenocarcinoma, NOS. Then, of course, we have the mucinous non-cystic carcinoma, also known as colloid carcinoma, and this is of prognostic significance as these patients do tend to have a better prognosis than ductal NOS. Certainly we have our signet ring, and I just want to point out that the definition of signet ring cell carcinoma in the pancreas is different from in other organs in the GI tract, where we have the 50% cutoff rule. At least according to the WHO, signet ring cell carcinoma in the pancreas should be comprised almost exclusively of signet ring cells. And of course, the important thing to rule out when you see a signet ring tumor in the pancreas is that it's not a metastasis from somewhere else. Certainly carcinomas with a squamous component have a worse overall prognosis than ductal carcinomas. Then we have our undifferentiated carcinomas, and then basically a variety of other more rare entities. So this is a picture of the ductal adenocarcinoma that we're all quite familiar with. So of course, ductal adenocarcinomas form gland or duct-like structures. This is actually a sample from a core biopsy showing an angulated duct with hyperchromatic nuclei. This is a resection specimen showing a large duct, a variant of ductal adenocarcinoma, and then another kind of run-of-the-mill ductal adenocarcinoma, this one that's actually involving the islets. I just wanted to make mention of this entity simply because of its prognostic significance. So this is a gross specimen, and you can see the mucin extrusion through the papilla, and as you know, this is a finding that's associated with intraductal papillary mucinous neoplasms. And IPMNs are significant, for one, because of their propensity to develop into a colloid or mucinous non-cystic type of carcinoma. They certainly also can be associated with ductal carcinoma NOS, but the colloid carcinoma is of particular significance because it has a better prognosis than your run-of-the-mill ductal adenocarcinoma. And I just included this picture of the undifferentiated carcinoma with osteoclast-like giant cells. And this is kind of an interesting entity in that at one time it was thought to have a better prognosis, but as data has accumulated, that it does not seem to be the case. Next we come to histologic grading of pancreatic carcinoma. And there are a number of different grading schemes out there. This is the one that's actually referenced in the CAP protocol. And so basically we have 4 grades. The well-differentiated, moderately differentiated, poorly differentiated, and undifferentiated. And you'll notice that the grading scheme recommended by CAP is very similar to the grading scheme used for colorectal carcinomas and for endometrioid carcinomas, in that it's purely based on the percentage of gland formation without any reference to nuclear atypia or mitoses or other factors. And obviously, the appeal to this system is that it's a relatively simple system to use, and it does have prognostic significance, particularly the high grade or the G3 or G4 tumors. However, there are certainly other grading systems out there that you might want to be aware of. And but first of all, I'll just show you some examples of grading using this system. So this is an example of a well-differentiated ductal adenocarcinoma. So this is when the tumor is comprised 95% of infiltrating glandular or ductular structures. Then we have some examples here of moderately differentiated adenocarcinoma. And of course, these tumors will have a mixture of glandular structures and more solid appearing structures, but at least 50% of the tumor is comprised of glandular differentiation. And then we have our poorly differentiated tumors, and so these are tumors that are comprised mostly of solid nests. Individual infiltrating cells, perhaps they have a little bit of signet ring morphology. And here's another example of a poorly differentiated ductal adenocarcinoma, where it's very hard to find a good glandular structure. Basically, you have a lot of small cell clusters and individual cells here in a desmoplastic stroma. So here's one of the major alternative grading systems for pancreatic carcinoma, and this is the one that's advocated by Dr. Whipple's group and also appears in the WHO Blue Book. So you can see that they look at a lot more criteria: gland differentiation, mucin production, mitoses per 10 high power field, as well as nuclear features. Now, interestingly, the final grade in this system is not a composite of these features. It's basically you take the highest grade in any one category, and that's the final grade. And you actually also take the worst area of tumor and base the grade on that, regardless of how significant a component that is. So this grading system has also been shown in at least one study to have prognostic significance. Although given that the CAP protocol or TNM system has also been shown to have prognostic significance, it might be just easier to go with the simpler system. So the next part of the checklist deals with microscopic tumor extension. And certainly these are the categories. We very rarely would see a pancreas resected for carcinoma in situ, unless it was an IPMN sort of situation. So the other categories that you can choose are that the tumor is confined to the pancreas, or the tumor invades one of the structures within or surrounding the pancreas. So the ampulla of Vater or sphincter of Oddi, the duodenal wall, the peripancreatic soft tissues, or other adjacent organs or structures. And certainly we have seen examples of resection with bits of stomach or portions of colon. So here's an example of pancreatic tumor invading the muscularis of the duodenal wall, and this is actually a very common finding. This is a section of the common bile duct, once again with infiltrating tumor which originated from the pancreas surrounding it. And the ampulla of Vater is, of course, also very commonly invaded, and here you can see tumor percolating into the ampulla. And of course, it's very rare that we see a case where the tumor has not infiltrated the retroperitoneal adipose tissue. So the vast majority of tumors, at least that we see in our practice, are in fact T3 tumors. So as I said before, often the tumor size becomes irrelevant as the tumor is already beyond the pancreas and thus is already a T3 tumor. Next we come to margins. And this is actually a very critical component of the grossing and the assessment of pancreatic cancer specimens. So obviously the first choice is that margins are uninvolved by invasive carcinoma, and then we're obligated to give a distance of the invasive carcinoma from the closest margin in millimeters. And in fact, usually the closest margin is in millimeters or less, just basically due to the confines of the anatomy. Often the surgeons just basically have little room to play and really can't do a more extensive resection. Now, the question arises, of course, what constitutes a positive margin? We certainly have more guidance in other cancers, such as rectal cancer, where we know that tumor within 1 millimeter of the radial margin is considered a positive margin, but we don't have any such clear guidance in the CAP protocol for pancreatic cancer. So there seems to be actually a little bit of a divide across the Atlantic with respect to this, where our European colleagues tend to call anything less than 1 millimeter a positive margin, and so we should keep this in mind when evaluating any literature from Europe, whereas in many centers in North America, basically margin positivity is tumor at the margin. In any case, I definitely recommend that you report when tumor is within 1 millimeter of the closest margin. Then we come to carcinoma in situ, which could be either in the form of a high-grade IPMN or a Panin-3 sort of lesion. So margins are either uninvolved or they're involved. And you have two choices on the checklist as to whether CIS is present at the common bile duct margin or the pancreatic parenchymal margin. Now, I would argue that if we're seeing CIS present at the common bile duct margin, we should seriously reconsider as to whether this is a pancreatic primary or a extrahepatic bile duct primary. So the next choice is margins involved by invasive carcinoma. And the margins that are specifically listed in the CAP checklist are the Unsnet process margin, which they use as a synonym for retroperitoneal margin. And this is defined as the non-peritonealized surface of the Unsnet process. Now, we're going to get into a bit of a discussion very soon about the use of these words synonymously, because I would argue that the Unsnet process margin is simply a component of the retroperitoneal margin, and there are other components that should also be assessed. Certainly, the distal pancreatic margin needs assessment in a Whipple specimen, as well as the common bile duct margin. There are different ways of assessing this proposed, but the CAP protocol recommends doing full on-FAS margins to evaluate these, and that in fact is our practice. And certainly in our practice here, the vast majority of the time these margins are assessed as intraoperative consultation specimens. For distal pancreatectomies, the proximal pancreatic margin is the main margin of interest. Then the final choice is invasive carcinoma involves the posterior retroperitoneal surface of the pancreas, and I think this merits further discussion. So before I discuss this beautiful image here, I just want to extend my gratitude to Dr. Vlad Maximov of Grand River Hospital in Kitchener. And I can definitely say that nobody has known and loved the Whipple specimen as much as Vlad Maximov. And this is entirely his work here in terms of dissection and painting, and the thought that went into conceptualizing these structures. And I understand that his work is currently getting ready for publication. So thank you, Vlad, for this very useful picture, which delineates the portions of the posterior margin of the pancreas specimen. So just to orient you, this is cranial, this is caudal. This structure in yellow here is a portion of the superior mesenteric vein that was resected with the specimen. Here in green, we have the pancreatic distal margin. In red, we have the vascular groove. In black, we have the uncinate margin, which is also known in the literature as the superior mesenteric artery margin, because this is the part of the uncinate process that is directly adjacent to the superior mesenteric artery. And the implication of margin positivity in this area is that there is tumor left behind in the region of the superior mesenteric artery. And then over here in blue, we have the posterior surface of the uncinate process. So in order to truly say that we have an R0 resection, we want to thoroughly sample these surfaces. And there are a number of different protocols out there in the literature. As I mentioned before, we take the pancreatic distal margin on FAS, but basically the vascular groove and the uncinate margin we assess with perpendicular sections. Also, if you do happen to get venous resections, either superior mesenteric vein or portal vein with your Whipple, make sure that you assess the vein margin. So either end put on FAS should suffice. So I just wanted to show you some examples where the posterior retroperitoneal margin of the pancreas is involved or close. And once again, it raises the issue of what constitutes a positive margin. So here's an example where we have frank infiltrating tumor at the ink on the margin. Here we have an example where the tumor is less than 1 millimeter, and yet another example where we have infiltrating glands less than 1 millimeter. Our current practice here is to call these margins negative, but specify that they're within 1 millimeter. Certainly in some centers, and I would say most of Europe, this would be called a positive margin. I also wanted to show you an example of some of our vein margins. These are actually often also assessed as intraoperative consultation specimens. And so this is an en-face margin of the superior mesenteric vein. Most of this looks okay, but you can see there's an area of focal irregularity there. And on higher power, you can clearly see there are infiltrating glands where they don't belong. So this is obviously assisted intraoperative consultation with the thought that they would attempt to revise the margin intraoperatively if it were positive. The next section that we come to in the protocol is that of treatment effect. And this is relatively new, certainly in our center, and I believe that there are only a few centers in North America that are really doing neoadjuvant therapy for pancreatic cancer in a serious way. So basically, the patients who are selected for neoadjuvant treatment are those who are theoretically fit for surgery and have a borderline resectable tumor. And so there are a couple of philosophies around this. One is that neoadjuvant treatment may downstage a tumor or convert a borderline or unresectable tumor to a resectable sort of situation. And the other is in these patients, sometimes one might want to basically assess the biology of the tumor, kind of akin to what happens with chemotherapy for colorectal liver mets. So CAP does advocate grading tumor response for pancreatic cancers that have had neoadjuvant. And I find this concept actually quite difficult just because of the nature of pancreatic tumors. Basically, our choices are no residual tumor, and I have yet to see a complete response to neoadjuvant chemorads in pancreatic cancer. Marked response, which would be minimal residual cancer, I also have yet to see that, or moderate response, which is residual tumor outgrown by fibrosis. As we know, pancreatic cancers tend to have a lot of fibrosis or desmoplastic reaction, so it's very difficult to differentiate between a moderate response and no definite response. And this is just to show you a gross example of our first neoadjuvant case that actually came to surgery a few years ago. And just to orient you, here is the duodenum. Here's a portion of the common bile duct. And here on the posterior surface of the pancreas is a bit of superior mesenteric vein that is plastered to the tumor. The next component of the checklist is lymph-vascular invasion, and our choices here are not identified, present, or indeterminate. Now, in the current CAP protocol, there's no differentiation between small vessel invasion and large vessel invasion, and I think part of that is because they don't think that we can reliably tell the difference. But in some cases, I think it is quite obvious, as in this example, where it is obviously a vein. And one comment I want to make here is that vessel invasion alone does not affect the T category. So if you were to find yourself in that rare situation where you had a tumor less than 2 centimeters that was confined to the pancreas and the only extrapancreatic disease was vessel invasion, that would not make it a T3. And just some more examples of vascular invasion. So it can be quite focal within a vessel or more obvious. And here's a nice example of lymphatic pancreatic invasion, and here's a vein that has been pretty much obliterated by cancer. And this one becomes fairly obvious in that it's extrapancreatic, but if it's within the pancreas, this sort of lesion you can actually mistaken for a Panin type of lesion. Next, we come to perineural invasion, which we all know is an extremely common finding in pancreatic cancers. And once again, the choices are not identified, present, or indeterminate. And despite the fact that it's so common, it actually is an adverse prognostic factor. And here's just a nice example of ductal adenocarcinoma with perineural invasion. So next we come to the pathologic staging. So first we have our TNM descriptors. So you can have multiple primary tumors, which is a relatively rare phenomenon in the exocrine pancreas. Recurrent, also extremely rare that there is a redo surgery on the pancreas, so that I can think of two examples in my practice. Why? Post-treatment, which, as I said, is becoming more common in some centers, and then probably the least frequently used TNM descriptor, which is A for autopsy. So here are our choices when it comes to primary tumor. So cannot be assessed or no evidence of primary tumor. Carcinoma in situ, which would be relevant for Panin-3 lesions or high-grade IPMNs. T1, which is tumor limited to the pancreas 2 centimeter or less in greatest dimension. T2, which is more than 2 centimeters and limited to pancreas. I find that both of these are quite rare. T3, which is tumor extending beyond the pancreas but without involvement of celiac axis or superior mesenteric artery. So I think this is a departure from a lot of other tumors in the GI tract, where the difference between a T3 and a T4 tumor is serosal involvement or involvement of adjacent structures. Basically, a pancreatic cancer can involve any adjacent structure and still be a T3 as long as those structures are not the celiac axis or the superior mesenteric artery. So the reason for this distinction is purely based on the implications for tumor resectability. And the traditional cutoff for resectability is involvement of celiac axis or superior mesenteric artery. And I thought I would note that this notion is currently being challenged, and certainly in some centers, people are doing arterial resections of portions of the superior mesenteric artery. So it will be interesting to see if in the next edition the T3 and T4 definitions remain as they are. Next we come to regional lymph nodes. And basically, your choices in pancreatic cancer are N0 or N1. So, from a staging perspective, whether there's one node positive or there's 20 node positive, it's still N1. However, certainly there are studies that show that the more involved nodes, the worse prognosis, and that increased lymph node ratios, that is the number of positive nodes versus the number of total nodes, higher ratios portend a worse prognosis. For pancreatic cancer, the CAP protocol does recommend retrieval of 15 nodes for optimal assessment, but there haven't been the extensive studies that have been done in other organs such as colorectal. So these are the diagrams found in the CAP protocol that show the regional lymph nodes that are of importance for staging pancreatic cancer. And I won't go into these in detail. I think the simplest way to approach this is that the vast majority of time, any lymph node that you find with your resection specimen is a regional lymph node. I think the difficulty comes when we get separate lymph nodes submitted by the surgeon, and it's very important that we clarify with the surgeon where those nodes are from so that we can determine if, in fact, a lymph node metastasis is regional lymph node disease or if it's, in fact, distant metastasis or M1. Here's an example of a lymph node metastasis, which, as I said, is also a poor prognostic factor. Next, we come to distant metastasis, and your basic choices on the checklist here are not applicable, or PM1, distant metastasis, and the checklist asks you to specify the site. In previous editions of TNM checklist, there was a PMX, cannot be determined. This has been removed. There still does exist a PM0, but that can really only be used if an autopsy has been performed. I wanted to raise one important point about PM1. Obviously, we would all call PM1 if we got a separate omental nodule or liver nodule that was consistent with metastasis, but positive peritoneal cytology of any kind, so that is either acidic fluid or some sort of peritoneal washing, is by definition PM1 because it's associated with an extremely poor prognosis. Next, we come to additional pathologic findings, and certainly pancreatitis is a very common finding in these specimens, but I wanted to spend a little bit of time on this entity of pancreatic intraepithelial neoplasia. So pancreatic intraepithelial neoplasia, really these constitute the putative precursor lesions of pancreatic ductal adenocarcinoma. And here are the definitions that are endorsed by the CAP. So you have normal, which is non-mucinous flattened or cuboidal epithelium, Pannon's 1A and B. So these are both comprised of mucinous epithelium without dysplasia, the difference being 1A is flat and 1B is papillary. Pannon 2 then is mucinous epithelium with dysplasia, mild to moderate, and Pannon 2 lesions can be flat or papillary. And then finally, Pannon 3 is either flat or papillary mucinous epithelium with severe dysplasia. And Pannon 3 is also categorized as carcinoma in situ and gets the T category of PTIS. So here are some examples of Pannon. Just for comparison, here's a normal duct. Here's a duct with something that I would call Pannon 1A with this tall mucinous epithelium, but with no unequivocal dysplasia. Then Pannon 2 with basically still mucinous epithelium, but with some stratification here and nuclear enlargement atypia, such as one might see in an adenoma. And then finally, Pannon 3. And Pannon 3 is often categorized by these little micropapillary projections and bleeding of cells into the lumen. Now, in terms of the reporting of these, CAP does recommend that they're reported, and specifically that Pannon lesions are reported at the margin. Actual practice in this area, I think, is debatable. Certainly, I would advocate reporting all Pannon 3 lesions at the margin, because essentially these are high-grade dysplasia. As to the lower grade Pannons, I really don't think we understand the biological significance, given that a lot of otherwise normal pancreas specimens will have foci of Pannon 1 and Pannon 2. In terms of ancillary studies, there actually are no routine ancillary studies that are endorsed in the CAP protocol. But of course, if you end up doing any special immunohistochemistry or molecular studies, you should include that in your report. Next, there is a section for clinical history, and suggested inclusions here are neoadjuvant therapy, which we've already discussed, familial pancreatitis, which is a risk factor for pancreatic cancer, and then familial pancreatic cancer syndromes. And there are several of these, certainly BRCA2, familial atypical mole melanoma syndrome, Putz-Jeghers syndrome, and Lynch syndrome are a few of these. So if you do get a history of that, please put it in the protocol. And that brings us to the end of the checklist, and thank you for your attention, and I'll be happy to take any questions.
Dr. John Shrigley here. Are there any questions from anybody on this call? And if so, please put them in the chat window. I guess one question I would have, Corwyn, is that as you probably know now, we have a mechanism now of a group or a team of Canadian pathologists who have been appointed to the Canadian Partnership Against Cancer to be the protocol review team for the CAP checklist protocols at a national level. And one question I would have is there any improvements that you could suggest in the current CAP checklist that you might want to pass on to Dr. David Dryman, who's our representative?
Well, yes, I think we're going to have to reevaluate the checklist in terms of basically the changing treatment regimens. One thing I think we should look at is the overall staging. Really, is the T3 versus T4 are those the right definitions now that people are doing more aggressive surgeries and resecting portions of the superior mesenteric artery? I really think we need to take a look at the treatment response algorithm. Has that algorithm that's currently in the CAP checklist been validated? And I would also like to revisit the part in the CAP protocol about reporting all PANNs at the margin, because I think that this can be quite disconcerting to surgeons or to patients who basically see that there's a report of a neoplasm at the margin, and I think you can have a perfectly good R0 resection, but cause some confusion by mentioning PANN at the margin, particularly the low-grade ones.
Well, I see one question here, Corwyn. If we could just, how do you grade? I don't know exactly. It's from Dr. Eldian. How do you grade a focus of single malignant cells in others? How do you grade How do you grade the focus of single malignant cells in an otherwise GI tumor, given leveling confirmed these are single cells and not tangential sectioning of a gland?
Yeah, I mean, I think that would depend very much on which grading system you're choosing, and basically the CAP protocol doesn't give us a lot of guidance in this area, although in general principles with GI cancers, usually you grade the worst area of the tumor. We often get this question in colorectal carcinomas as well, and I understand that the difficulty is when you have a tumor that, say, is greater than 50% glandular, but then you have a distinct area that is of higher grade. Do you call that moderately differentiated, or do you call that poorly differentiated? And my best answer to that is, if it's clearly a distinct, different area from the rest of the tumor and it's higher grade, I would go with the higher grade. If it's kind of mixed in with the tumor, I think and you're using the system that's based on percentage of glandular differentiation, I think you have to stick to that. Of course, if you're going with the Cloppel system, that kind of takes care of that question for you, because by definition you're grading based on the highest grade component.
Thanks, Corwyn. I don't see any other questions. Do you, Sarah? I think we're good to go. So on behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I really want to thank Dr Rowsell for a truly comprehensive, informative, and a very clear presentation today. I think the lack of questions is testimony to the clarity of the presentation. Now, this is the first session in the third series of our CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure that these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of the completed online evaluation. Once the WebEx recordings of this presentation become available, it will be made available for wide distribution via links by Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and the recorded presentations are eligible for CME credits. In order to receive your credits for attending, viewing the education session, you must complete an evaluation for each session accessed or viewed in its entirety. The link to the web-based survey has been included in the sessions notices that were previously distributed prior to this session. Please note once again that CME certificates for each CAP checklist education section will only be available for 1 month following the presentation date. The sessions will remain available electronically for an undetermined period of time. Please refer to the session notice for the exact deadline date. Now, our next presentation is going to be on a checklist related to head and neck cancers, and it's on January the 11th, 2012, and our speaker is going to be Dr. Bayardo Perez-Ordonez from University Health Network in Toronto. So I look forward to hearing from you again in the next presentation, and I wish everybody a very happy holiday season, and we'll see you in January.